to you. So good afternoon, everyone. Welcome to our Yale Sleep Seminar. My name is Ritika Thapa, and I'm one of the faculties here. Before we start the seminar and introduce our today's speaker, I'd just like to make a few brief announcements. Please make sure that you're muted. And then in order to receive the CME credit for attendance, please see the chat room for instructions. And if you have any questions or comments during the presentation, please use the chat room or take the opportunity to unmute yourself at the end and ask questions. And Dr. Weir will moderate the session in the end. And with this, I will hand it over to Dr. Ian Weir, who is the Fellowship Director of the Sleep and Pulmonary Medicine at Norwalk Hospital, to introduce our today's speaker, Dr. Chloe Deng.
All right. Well, thank you so much for everyone joining us today. We're really going to be in for a treat. I have the pleasure of introducing Dr. Chloe Deng. She started off her career in medicine at the Lake Erie College of Osteopathic Medicine, and then did her internal medicine residency at Unity Hospital in beautiful Rochester, New York. And we were lucky enough to attract her to our program at Norwalk Hospital, and she's finishing up her sleep fellowship. Will graduate at the end of June. And I'm really excited and very happy to find out that she will be doing a sleep medicine position at UMass Memorial Medical Group. And it's going to be a fantastic opportunity for her. So without ado, I will go ahead and get started and take it away, Dr. Chloe Deng.
Thank you, Dr. Weir, for your introduction, and good afternoon, everyone. My name is Chloe. Before I actually get started, I'm just going to share this disclosure page stating that I have no conflict of interest, and then this is the code for the CME credits, which will also be in the chat later. So as a fellow and just as a trainee for the past few years, I naturally tend to focus a lot on disorders and what's abnormal, but I've started to realize that there's actually a lot of patients that may have isolated normal symptoms that resemble kind of the pathologic features in many of the sleep disorders that we see. So the main objective of this talk is to review those isolated symptoms and normal variants that we may or may not know, and then explore any studies that look into any associated mortality and morbidity, and then discuss treatment guidelines that are available to date. So under the umbrella of insomnia, there are two groups. So there's excessive time in bed and short sleepers. So in contrary to kind of the perpetuating factors in insomnia, the excessive time in bed can actually be normal. And so this is where an individual reports kind of prolonged sleep latencies or long periods of wakefulness during the night, but they have no complaints of insomnia nor show any daytime impairments. And then in the children, this pattern might emerge where parents kind of have unrealistic expectations for their sleep needs and kind of just routinely allow too much time in bed for the child. And then in the adults, this might just be the non-complaining groups who just spend a lot of time in bed that's needed for sleep. And for example, you might have patients who are retired or unemployed, and they just spend a lot of time in bed, but they're not particularly bothered by the expanded period that they're awake for. And currently there's no adverse consequences that have been described, unlike the chronic insomnia disorder. And so really the treatment here is just reassurance. And then I just wanted to highlight and bring this page up because this is the diagnostic criteria for chronic insomnia. As you can see here, I highlighted it in green. These are pretty much all the daytime symptoms that they would have to have, at least one of them, in order to fulfill this diagnosis. So naturally, those who spend excessive time in bed, that does not necessarily have insomnia, and therefore we don't treat it as such. And so the next normal variant is actually short sleepers. So it's someone like Elon Musk who just spends less than 6 hours of sleep per night, and they don't have any sleep or wake complaints, and they show no apparent daytime dysfunction. And these individuals are actually considered normal short sleepers. Now, what's important to mention is that these individuals may have short sleep duration, but it's not a result of them chronically or voluntarily restricting their sleep in the case of insufficient sleep syndrome, but it's more of a constitutional disposition for reduced sleep. So we might be kind of well aware of this bell-shaped curve of what is the habitual sleep duration, and these patients just fall into this small group of short sleepers. They also found like a gene mutation that might be contributing to their natural sleep duration, and these are the genes that they have mentioned. And then overall, the clinical significance is pretty much undetermined at this point. You know, there are studies that have linked short sleep with metabolic, cardiovascular, and other forms of medical morbidity, but we're really not sure if this is kind of a causation or is this a confounding variable, because these studies don't really distinguish individuals who have short sleep in, let's say, the context of insomnia, or those who are voluntarily restricting their sleep, as opposed to those who are natural short sleepers. So we say that this is a normal variant, and then therefore we don't really have any treatment guidelines specifically for this. And then just shifting gears to kind of the realm of hypersomnia, just like how there are normal short sleepers, there's also normal long sleepers. And a long sleeper is someone apparently like Mariah Carey who spends more than 15 hours of sleep per night. And these are the individuals, at least in the adults, who spend at least 10 hours of sleep per night. And then in children and adolescents, it's pretty much 2 hours more than their age-specific norm, which I have listed here. There might be very, very slight discrepancies depending which resource you use, but this is a very nice slide that we can kind of share with patients, stating what is the normal sleep duration. And so in the adolescents and child group, it's pretty much 2 hours above this upper limit of normal. And then again, back to this bell-shaped curve, the long sleepers would fall into this small category here. And then in order to really identify these long sleepers, it's really important to have a pretty consistent daily pattern that's documented by sleep logs, preferably confirmed by a etigraphy that shows 10 or more hours of sleep per night over a minimum of 7 days. And so these long sleepers, they tend to seek medical attention when they actually develop sleepiness, but this is more so of them being forced to reduce their sleep time to what is required for them. And this just implies that they really shouldn't have any complaint of excessive daytime sleepiness when their sleep needs are fulfilled. And then you tend to see this pattern begin in childhood, and then it can be well established in their early adolescence years, and then it'll persist throughout their lifetime. So like many of us here who have, you know, educational and occupational demands, these long sleepers can function quite reasonably well on 9 hours of sleep a night, you know, during school or work week. And then they might compensate on the weekends or holidays by sleeping 12 hours or more. And this just really highlights, you know, the importance of getting a good history on their sleep schedule. And then in regards to the prevalence, about 2% of men and 1.5% of women have been reported to sleep at least 10 hours a night. And then there was a population-based data from about 20,000 adults in the US that showed 8.4% of them that reported sleeping more than 9 hours. And then they found a higher prevalence among women. So studies pretty much have consistently found like increased mortality, incident diabetes, cardiovascular disease, stroke, heart disease, and obesity associated with long sleep. However, again, not really clear if most of these individuals were naturally long sleepers or if they really had disorders that caused them to sleep for long duration of hours. And here in this systematic review and meta-analysis specifically, one of the limitations that they actually mentioned was that they did not adjust for confounders. So long sleep duration was also found to be associated with retirement, unemployment, being separated or divorced, and the use of antidepressant. And interestingly, they also found high levels of CRP as well as IL-6 concentrations. And then this was the interesting part where they found a protective effect against AFib and heart failure in adults. And there was also a high heritability and concordance between twins where they linked this to multiple genes that are part of the circadian and as well as other genes like the potassium channel regulatory protein genes. And this DEC2 was also mentioned earlier with the short sleep duration. So in terms of kind of more of the objective findings, what we'll typically see is that a lot of these long sleepers actually have normal architecture and physiology, and they have normal sleep efficiency and timing, and their absolute stage 3 sleep is actually normal. They just might have a little bit more of N2 and REM sleep. But most importantly is that there should be no sleepiness on MSLT, especially if they were able to obtain their preferred sleep amounts prior to the nights prior to the MSLT. And so the important part, and probably the difficult part, is to differentiate these long sleepers from those with central disorders of hypersomnolence, sleep-related breathing disorders, or kind of other causes of hypersomnolence. And this differentiation, unfortunately, can be a little bit more difficult in the younger population because naturally they just have a longer normal continuum of sleep duration. But really, the point here is that this diagnosis is more so of a diagnosis of exclusion. So you really have to exclude all of these specific diagnostic features. They can't have any symptoms when the adequate sleep is obtained. And then one thing that they did mention is that it might be hard to differentiate these from idiopathic hypersomnia, but trying to see if they get refreshing sleep, if they sleep longer, and if the sleepiness disappears when these long hours are enforced. And that's kind of how you're going to be more leaning towards long sleeper than idiopathic hypersomnia. And then because, again, like short sleepers, long sleepers are considered normal variants, there's really no treatment guidelines. And then moving next to sleep-related breathing disorder, we get a lot of referrals for evaluation of sleep apnea. And a lot of these complaints are specifically from, snoring that's reported by bed partners or family members. And so we know that snoring can actually be habitual. And this is basically just the respiratory sound that's generated in the upper airway when we're sleeping. And it's specifically the vibration of our uvula and soft palate. But most importantly is that you can't designate, primary snoring or habitual snoring if they have any respiratory events like apneas, hypopneas, raras. And they should not have any symptoms of daytime sleepiness or insomnia. And then just the most problematic part usually is that it can be bothersome or disruptive to the bed partners. So we know that snoring is a cardinal symptom of obstructive sleep apnea, which is why it's very important that if they have any symptoms like apneas, daytime sleepiness, insomnia, or if they have comorbid cardiovascular disease, it's important to rule out sleep apnea with either an in-lab or home sleep test. And then in regards to the prevalence, it's thought that occasional snoring is almost universal. However, they can't really estimate it because the definition kind of varies, but they found that in children, it's probably 10 to 12%. And then the Wisconsin cohort study showed that in adult women, that's 24% who had snoring, and then 40% of adult men who had snoring. And this prevalence tends to increase with age in both sexes, with the exception that that prevalence might tend to decrease after like age 70, but it's thought that maybe it's just due to decreased hearing. And so now in terms of the risk factors, we know most of these, being an adult man, obesity, having nasal obstruction, specifically having adenotonsillar hypertrophy in children, the ingestion of alcohol, muscle relaxants, opioids, or other substances that can decrease upper airway muscle tone can predispose an individual to snoring. And then smoking, particularly in males, has been shown to be a risk factor as well. And then among children, the exposure to secondhand smoke also increases the risk. And then in terms of pregnancy, snoring tends to increase from 8% in the first trimester to 21% in the third trimester. So current literature shows that habitual snoring may be associated with worse school performance in children, but conclusive evidence for this is still quite lacking. And then some studies suggested that in the adult population, those who snore have higher prevalence of cardiovascular disease. But then when you account for obstructive sleep apnea in these large observational studies, there's no increased risk of cardiovascular mortality. The other thing is that there were very few studies who showed maybe they had a predisposition to atherosclerosis in the carotid artery, but then subsequent studies didn't find this association. So kind of the data there is still mixed. And then in terms of pregnancy onset snoring, they did find an increased risk of gestational diabetes, hypertension, as well as preeclampsia. And so we know that, or at least we think that having snoring may be of risk for developing sleep apnea when, there's increase in age or if there's weight gain, but really we need further research to establish kind of these long-term health outcomes of snoring once we exclude, those with obstructive sleep apnea, and really trying to differentiate if snoring is a risk factor or if it's a prodrome for the development of sleep apnea. So this is a very nice slide that I got from the German clinical practice guidelines for the treatment of snoring. So they just recommended pretty much general measures of lifestyle, sleep hygiene counseling, avoidance of nicotine, and modification of any head position. And then they kind of just broke it down a little bit more. So things like weight loss, position therapy, surgical options, if they have any nasal obstruction or if their anatomy is suitable for it. And then they also recommended mandibular advancement. So mandibular advancement or oral appliance was actually also recommended in the AASM guidelines that was updated in 2015. So our guidelines basically recommend that we prescribe oral appliance rather than no therapy for adults who request treatment for primary snoring. And if you actually read kind of the fine lines, it's really recommended for patients who fail conservative measurements and are still requesting for further treatment. Now, another isolated symptom, which can actually be normal, it's what's called cataphrenia. I actually just learned about this as I was preparing this talk, and it's basically sleep-related groaning or moaning. And the hallmark of this condition is deep inspiration that's followed by prolonged expiration and a monotonous vocalization that resembles the groaning. Unfortunately, when I converted my Google Slides to PowerPoint, it doesn't let me play this anymore, but I can definitely share this slide with anyone who's interested. It's just a very nice example of cataphrenia. And so basically, this pattern can also sometimes be called bradypnea or low respiratory rate. And these recurrent episodes can actually resemble central sleep apnea, except for the fact that central sleep apnea is not associated with vocalization. So this is a nice example of a 22-year-old who didn't have any complaints or risk factors for sleep apnea, but bed partners was reporting kind of these nocturnal groanings. And you'll see here kind of how there's no flow and there's a lack of effort that could potentially resemble central sleep apnea. But if you see here in the snoring channel, there are sounds. So these are the vocalizations. So these can potentially be erroneously scored as central sleep apneas, especially if they kind of missed a snoring channel. So I thought that was quite interesting. And so pretty much these patients are unaware about the sleep groanings that they have or the nocturnal groanings that they have, but they are usually seeking attention because their bed partners or their family members are concerned. And they can actually be quite bothersome because these events can occur nearly every night, and sometimes several episodes can occur in one night and often in clusters. But most importantly is that it's not a parasomnia, it's not associated with sleep talking, and that there's no body movements, and there's also no observed respiratory distress, and their oxygen saturation remains normal. So cataphrenia is thought to be rare. The onset tends to be in like childhood, adolescence, or young adulthood, but there's no apparent gender predisposition. So interestingly, they did this social media survey to kind of get a little bit more information about cataphrenia, and that's where they actually found that the competitive swimming was a potential risk factor. And from this, they concluded that there's really no clear long-term health consequences of cataphrenia. but it could be a pretty big social problem. So given that it's a benign phenomenon, there's really no treatment guidelines, but there's actually a lot of studies out there that have shown CPAP being effective in eliminating or reducing these groanings, but they don't really know what the mechanism is. They've shown that oral appliance also is effective, as well as oral surgeries. Next, we're going to move on to parasomnias. Really, the only symptom here that's considered normal is sleep talking. It's also known as somniloquy. And so the essential feature here is just talking with varying degrees of comprehensibility, and it can occur any stage during sleep, non-REM or REM. The sleep talking can be idiopathic, but it can also be associated with other parasomnia, so it's important to evaluate for that. And then the sleep talking can follow either arousals for sleep, or it can cause them, but it's less rare that they do that. So these sleep talkers are usually unaware that they're doing it, but again, it's reported by the bed partners or roommates. And sometimes it can actually be quite bothersome because they could be either really loud, or they can be speaking a lot during the night, or sometimes it could be like vulgar or offensive, especially to the ones who are listening. So sleep talking is actually thought to be highly prevalent. There was a study that found a lifetime prevalence of 66%. It's more common in children, and then they start to be less in the adult population, about 5%, but there's no consistent sex differences that they're able to find. And again, like how I mentioned earlier, they could be associated with parasomnias like RBD. So just noting that those vocalizations are usually more loud, emotional, and profane, as well as being associated with some behaviors that correlate with sleep. It could also be associated with sleep terrors, but usually it's more with an intense arousal or agitated behavior. And then other conditions that it could also be associated with, which is important to rule out, is nocturnal seizures, which tend to be more of stereotypical vocalizations. And then it has also been seen in those who have PTSD. So the other condition that sleep talking needs to be differentiated from is cataphrenia, which we just talked about earlier, which is this audible nocturnal groaning. Cataphrenia is actually more common in REM, and you'll see this sustained vocal cord activity on the EMG. And because overall it's thought to be an isolated symptom, there's really no treatment guideline, but there are some experts who suggest, just good sleep hygiene. And if it becomes bothersome to the partners, they can wear earplugs, or they can consider sleeping in different rooms, where Dr. Ware likes to say a sleep divorce. And so I'm going to move into our last disorder category, which is sleep-related movement disorders. So they fall into three groups. The first is excessive fragmentary myoclonus. And essentially what this is that it's just an incidental PSG finding. And it's characterized as these small movements in the corner of the mouth, fingers, toes, or sometimes there's actually no physical visible movements at all. And overall, these findings don't have any associated clinical consequence. It's just that if you see large limb movements, then naturally you exclude the diagnosis of this condition. So the ASM manual actually does not provide any amplitude criteria for this, but they do include these three criteria where the maximum EMG burst is 150 milliseconds. It has to have at least 20 minutes of REM sleep with this fragmentary myoclonus pattern, and you have to have at least 5 EMG potentials per minute that needs to be recorded. So this is a leg EMG pattern that's consistent with fragmentary myoclonus that's in N2. And you'll see them right here. And again, you need at least 20 minutes of this in REM sleep to call it excessive fragmentary myoclonus. So this condition is a non-REM phenomenon, although you might see this in wake or even in REM sleep in some patients, but pretty much these movements tend to resemble like phasic twitches in REM. However, they're not as common as the phasic twitches that we see. And the main difference is that they're more widely dispersed throughout the sleep epoch, whereas the phasic REM twitches are more clustered together. And really the big significance of this finding is that it's just within the differential diagnosis of other sleep-related movement disorders. So we just have to consider those when it's seen. Now, patients are usually not aware of this, and they usually don't have symptoms relating to this, even if they have other coexistent sleep disorders. So then in terms of prevalence, most cases have actually been reported in adults, and they found that it's predominantly in males. So there was just one study where it has been found in all of the 62 patients with various sleep disorders. And however, if you actually look at kind of the more general population, 9% of healthy sleepers can have this finding without any awareness. Now, numerous causes of chronic sleep fragmentation may actually be associated with excessive fragmentary myoclonus. It's been described in association with obstructive sleep apnea, primary central sleep apnea, sleep-related hypoventilation syndrome, narcolepsy, periodic limb movement disorder, as well as insomnia. And what they found was that the twitching tends to intensify during periods of increased hypoxia. And they also have been reported to commonly occur in those children with Niemann-Pick disease type C, but overall no specific precipitating factors that have actually been reported. So overall, this course is, not really well studied. It does appear to be benign, and non-progressive, and there's really no serious consequence that has been described, especially if it's occurring in isolation. So in terms of the specific findings that you'll see is that there's going to be a lot of associated sleep abnormalities and disruptions. And so it's pretty much these isolated, very brief asymmetrical and asynchronous EMG potentials in various muscle groups. So like the face, the trunk, the arms, the legs, and the amplitude can vary anywhere from 50 to several hundred microvolts. And then the taller amplitudes sometimes are usually associated with more visible movement, whereas the smaller ones might just be like fasciculation potentials, and you don't actually see movements with that. Now, these potentials can also last quite a long time, anywhere from 10 minutes to several hours, and you tend to see them at sleep onset, but they can also continue through non-REM. But when they're awake, you might also see that as well, and it can sometimes be associated with the K complex. The thing is that they actually have no ocular or autonomic features that's associated with this, and so that's pretty much the summary of this. But in terms of differential diagnosis, we kind of went through this in regards to the phasic REM twitches and the large body movements. But one thing that I just wanted to bring up is with the periodic limb movements, these have longer bursts, and the periods between the bursts are actually longer in comparison to the excessive fragmentary myoclonus. So overall, it still felt to be benign, and it doesn't require any treatment. Next is hypnagogic foot tremor and alternating leg muscle activation. So they are actually described together because the similarity in a number of their features suggest that maybe they're just not fully independent entities, but there's not enough evidence to really resolve this question. But basically, hypnagogic foot tremor is a rhythmic movement of the feet or the toes that occur at the transition from wake to sleep or during kind of light non-REM sleep. And it's a relatively common and normal finding. It can occasionally cause sleep disruption and sleep onset insomnia, but for the most part, not really a big complaint to patients. And then the other one is alternating leg muscle activation. So that is brief activations of the anterior tibialis in one leg, and then you see that activation in the other leg during kind of all stages of sleep, as well as arousals from sleep. There was an original case study that actually showed that it's not linked to actual movements of the lower extremity, so it's just muscle activation. And both of these findings can just be incidental. Now, in terms of their associated features, they are actually quite similar. There's sleep-related breathing disorders associated with both. With hypnagogic foot tremor, it's more associated with restless leg, and then in alternating leg muscle activation, it's more related to periodic limb movements in sleep. So there was a series of PSGs that they did that had different sleep disorders, and they found that 7.5% of those patients had this hypnagogic foot tremor finding. And this was pretty much the age group, from 14 to 72, but majority of these were in the middle age range. And then in terms of men and women, they were both equally affected, but not really sure what the prevalence is in the general population, just because this was more so from sleep centers records that they found this. And then in terms of alternating leg muscle activation, the first studies actually found that 75% of those patients were actually on antidepressants. So they think that the use of antidepressants may actually be a risk factor. Now, the only difference is that it was mostly more in males. And then in terms of the age group, they were also middle age predominant. Now, in terms of PSG findings, with the hypnagogic foot tremor, you do see brief repeated activations of the anterior tibialis in just one leg. And so this burst can be anywhere between 300 to 700 millisecond in duration. And you'll see this in that transition into sleep or early sleep stages. And the most important thing here of note is that it's between 2.25 to 3.3 seconds between the bursts. But in periodic limb movements, these durations are much, much longer. Now, this is just the ASM scoring. You need to have a minimum of 4 of these bursts, and this is the minimum frequency and maximum frequency. So I'll show an example here, which you'll see a 30-second epic of wake, and you do see this EMG burst in the left leg that's consistent with hypnagogic foot tremor. And then with alternating leg muscle activation, it's very similar to hypnagogic foot tremor, except that the EMG bursts alternate between the legs, and then the frequency is a little bit different. It's 0.5 to 3 hertz. And again, this is different from periodic limb movements in the sense that the duration between the bursts are shorter than the ones that you would see in periodic limb movements. And again, you'll need 4 of these bursts in order to label it as ALMA. And this is just another example, 30-second epic of wake, showing this pattern that's consistent with ALMA here, right here. And so pretty much, just re-emphasizing that we're not really sure what the manifestation in the general population is like, only because the reports of these movements have been primarily from the reviews of the sleep centers. So they think that, a lot of these factors could potentially be due to bias sampling, but regardless, as of now, we do know that they're really commonly present with concurrent sleep disorders. Overall, felt to be, pretty benign phenomenon, no clinical significance that we're at least aware of as of now. So really no treatment. But there was this one study of one patient that they found the treatment with pramipexole actually reduced the rate of occurrence of ALMA, but not really sure, how that's going to be used in the general population and what that actually means. So finally, we're going to move into sleep starts or hypnic jerks. It's the last isolated symptom that I'll be going over. And some of us may actually have experienced this before, where there's this like sudden brief contraction of the body at sleep onset. Sometimes it's associated with this impression of falling. It usually can be spontaneous, or it can also be induced by like an auditory or visual stimuli. Some of these patients might not actually recall these jerks, especially if it doesn't actually wake them up. So there's also purely sensory sleep starts that are just more of subjective sensory impressions that occur at sleep onset, but they don't associate with any motor activity. So exploding head syndrome, which is the sensation of hearing a very loud sound like explosion, but it's not associated with any pain, it's thought that it could be a type of sensory sleep start. And then there's also this term called intensified sleep starts. It's basically those who have both motor and sensory forms, but then they're also complaining of sleep onset insomnia because it just happens so frequently that they're not able to fall asleep due to that. It is thought that the prevalence is about 60 to 70%. It can affect all ages and both sexes. Some of the triggering factors that they have found is excessive caffeine or stimulant, intensive physical work or exercise prior to sleep, sleep deprivation, emotional stress. And case series there are a few case series that found an association with the use of SSRIs. And they've also actually found that it could maybe be commonly seen in those with Parkinson's. And so overall, it's thought that it's a universal component of sleep onset, although most of us don't really recall these incidents, and that this can pretty much occur at any age, but it's usually encountered in more so of the adulthood. Overall, the course is usually benign, except for the intensified sleep starts that can cause either anxiety, sleep onset, insomnia, or kind of the fear of falling asleep. And in rare cases, they might accidentally injure their bed partner. So the physiological mechanism kind of underlying sleep starts are still uncertain. They didn't find any pathologic finding that has been described, except for just one case study that showed auditory sleep starts was associated with brain lesions. And so they had a lot of theories in terms of what is the pathophysiology. So one is that it's thought to be caused by this sudden descending volleys that's originating in the reticular formation in the brainstem that activates the system instability while we're kind of in that transition between wake and sleep. And then because it's thought to be very similar to the startle response, they actually postulated that this sensory processing abnormality is more of a primary issue, and these motor manifestations are more so secondary. And then the last thing that they thought was that maybe sleep starts are just a response to kind of hypnagogic imagery. So regardless, in terms of the findings, it is pretty much, during that transition from wakefulness to sleep, and it's usually in the beginning of the sleep episode. And so you'll see EEG that shows either drowsiness or N1 sleep patterns. And then you can sometimes see that negative vertex sharp wave that's occurring at the time of the jerk. I'll show a quick example in a bit. And then the EMG recordings will generally show 50 to 220 millisecond of high amplitude potentials. And you might even see autonomic activations that follow these intense jerks. And so at the start, at these sleep starts, they might even have a brief arousal, or they might kind of return to sustained wakefulness when it happens as well. But overall, their physical, their neurologic exams, as well as their labs are otherwise normal. And usually we don't really need PSGs unless they do have, insomnia or frequent movements. So this is just an example of hypnic jerks. I couldn't really find a better example of it, but this was the only thing I was able to find. And so in terms of differential diagnosis, there's definitely a lot of physiologic as well as pathologic movements that can occur at sleep onset or during sleep. I won't actually go over all of these, but the only thing I wanted to mention is that with sleep starts, they're not stereotyped, unlike the myoclonic seizures, who are more stereotypical jerks that you'll see. And so in most cases of hypnic jerks, there's really no specific treatment that's needed. However, you can consider counseling, education to facilitate proper sleep hygiene, avoidance of triggers like caffeine, stimulants, fatigue, emotional stress, and then really just reassurance that this benign nature of the movements. Now, they did mention that those who suffer from excessive hypnic jerks, who have sleep disruption or sleep onset insomnia, that you can consider pharmacotherapy. So there were actually a few case studies that found that clonazepam was effective in reducing hypnic jerks. So, kind of take it with a grain of salt here. But pretty much, I know that was a lot of information, and I know there's a lot of experts here in the audience today, but in summary, I hope I was able to kind of highlight some key features of these isolated symptoms and normal variants that we may not be so familiar with. And hopefully I was able to kind of provide a general basis to help differentiate these benign variations from potential pathologic conditions, and just to know that mainly most of these are benign and usually no treatment is needed. So these are my references, and thank you for your time. And I'm just going to open it up to any questions or comments.
Wow, that was fantastic. That's a type of lecture that you don't really see too often. I've been in sleep medicine for a while now, and these things we teach them here and there in our fellowship, but you did a great job putting everything together and knowing what's normal and how to differentiate it from pathological disease. So that was really fantastic. So I'll monitor the chat, but we have a small enough audience, 47 people, which is pretty good, impressive, to watch this talk. So if anybody wants to unmute and ask a question, please go ahead. Otherwise, I'll monitor the chat if there's anything specific. Dr. Bakhtiar says, amazing job, Chloe.
Thank you.
Or if anybody wants to share their experience, because, again, something that we definitely see, patients may ask us, maybe our friends ask us, because they know we're in sleep medicine. If anybody wants to share any kind of their clinical experience with any of these conditions that maybe were normal variants, but maybe sort of presented more of a diagnostic challenge. So while we're waiting for people to chime in, I'll say that I've had some interesting stories. One was a woman who had the sleep starts, but they were very severe. And as you refer to it, most of the time it's benign, but it can cause some sleep onset insomnia. And we did the sleep study. We ruled out all kind of organic sleep disease. We couldn't find anything really significant. We talked about starting a little bit of clonazepam. I think she did it for a while. But yeah, that's something that can be pretty problematic for patients, and there's not a lot really to guide us in the literature. And then when you're reviewing these PSGs, I know we're doing more home studies these days and maybe missing some of these interesting PSG findings, but these are all like the foot tremors and everything else. Those are all like things that you will see if you look for it. And certainly they will be tested on the boards as a differentiating factor from periodic limb movements and disorder and other types of things. Oh, any comments about excessive yawning? Why does it occur?
I don't know.
Yeah, it's interesting. That would be something we probably next iteration of this, we can kind of add that and see what's been studied in the literature with the yawning. I think there's been papers on that and some discussions on that. My understanding is that there's no clear evidence why we yawn and why we do this, and is it associated with boredom or not? Not necessarily. So I don't think we know. I think I've heard a bunch of yawning from our fellows when I'm talking in the past, but that's kind of an expected consequence of the fellowship. But yeah. Here we go. What happens when people with long sleep now can't get 10 hours anymore? Would you consider treating them as insomnia or hypersomnia? So you describe these long sleepers. They say, yeah, if I get 10 hours, I feel great, but you know what? I work for this job that I can't possibly do that. I can only get 8 hours. How would you approach that type of patient?
I think a lot of education and counseling for the patient, because then otherwise we're just throwing medications at them when we know what the underlying cause is, right? Then now we're kind of more treating them as insomnia when they technically don't have insomnia. So I think it's a lot easier said than done, but more of that counseling education for the patients and really trying to push for them to get more long hours of sleep or try to compensate that, maybe on the weekends, or if, they're not needing to wake up early or do certain things that day.
Yeah, I think that's a really good point. I think, you're sort of stuck in that. Are you going to treat a normal variant with medication? In the case of long sleeper who's now sleepy because they need 10, but they're getting 7, or let's say, so they're 3 hours of sleep deprivation every night, which we know will be cumulative. So, you can imagine those people coming in the lab being labeled narcolepsy, or maybe not narcolepsy, but idiopathic hypersomnia. And now with the prevalence of, the wakefulness promoting medications, the cost coming down pretty substantially, could you make an argument to put someone on a wakefulness promoting medication if they just, can't physically do that? And that's a tough one. That's a personal decision that the doctor has to make with the patient to accept the risks of these medicines. And some people are in positions or jobs or whatever, they can't get those hours of sleep. So yeah, again, I think it's a personal choice. And that's why it's one of the things you mentioned when you have someone comes in and you're working up a hypersomnia, asking them, hey, because how many times we've had patients, like 10 hours, what happens when you get 10 hours? Oh, I feel fantastic. Oh, okay, now we have a long sleeper in the differential diagnosis. But if you ask someone who has idiopathic hypersomnia, oh, you get 10 hours, how do you feel? They still feel kind of sleepy. So that's a nice differentiating factor. But not all of us have the luxury of getting 10 hours of sleep. We have a few minutes left. Anybody have any other questions or comments they want to add? All right, fantastic. I know I just put a plug in for the 3 p.m. Yale Pulmonary Critical Care talk. It's on a great topic. So for those of you who are interested, you have time to attend that. And thank you, Dr. Deng. Fantastic job. Very impressed with your presentation. And thank you so much for doing this.
Thank you, Dr. Ware. Thank you, everyone.